ठीक है, सही। Assalamu alaikum everyone. So this is going to be another session of webinar from APPNA, and as we all know, we kind of talk about COVID-19 updates as well as try to answer questions and try to help our colleagues and SOEs get some knowledge from Pakistan as well, how they are doing there. So today we have Majid Shafiq, who's an excellent physician, and he's the interventional pulmonologist as well as intensivist, but I'll let him introduce, and then we'll get right on to his presentation, and then we will take questions at the end. Also, you can post your questions in Q&A, and we will try to get to as many questions as possible. Majid, please go ahead and introduce yourself and get started.
All right, great, thanks. Assalamu alaikum everyone. Yep, I'm Majid. I'm an interventional pulmonologist and an intensivist. And I think many, if not most of our esteemed attendees from Pakistan and also from North America have seen some of these webinars every day. We try to spend an hour talking about COVID and COVID management. And during the first half, one of us tries to speak slightly more formally and in slightly greater depth about some specific aspect related to COVID-19 patient care. But then, you know, the questions would be related to whatever aspect of COVID-19 that you want to discuss today, and we have an expert panel that'll go over that. Today, I will talk specifically about certain airway procedures among patients that are hospitalized with COVID-19. Many of these are intubated and on mechanical ventilation. And then the question comes up about a potential airway procedure that I, as an interventional pulmonologist, have to deal with. So I'll share some thoughts and some data related to those. So let me try to advance my slides. All right, I have no conflicts of interest. So this is what we will talk about today. We'll be discussing two distinct airway procedures today. One is a bronchoscopy at the bedside, so in the ICU, for instance. And the second one is a tracheostomy. Now, both of these are directly manipulating the airway. So as you can imagine, for COVID-19 that has a specific tropism for the respiratory tract, both of these pose a high risk for aerosol generation, which presents an occupational hazard to everyone who's in the room. Remember that there's a lot of talk about N95 masks and how they're amazing, but they're in short supply. But remember, the 95 and N95 stands for 95% of the time. 95% of the time, they will usually catch small particles that are, at least one of the brands claims 300 nanometers in diameter. So it's not offering 100% protection. And then moreover, the COVID-19 virion has a diameter that is estimated to be about 150 nanometers, not really 300 nanometers. So nobody knows, of course, but just remember, everything we do, does carry risks. And just because you have an N95 mask doesn't mean you should proceed willy-nilly with any manipulation of the airway tract. So you should only proceed if it's clearly indicated, because that's the best thing for you and your staff, and that's the best thing for your patient, as with any invasive procedure. So we'll talk specifically about when to do a procedure, and what should be the pre-op, intra-op, and post-op considerations. So first, the bedside bronchoscopy. When should we do it? Well, one instance is when you really need to do a bronchoalveolar lavage, or a BAL, to diagnose somebody who is suspected of having COVID-19. You should only reserve it for cases where, having a formal COVID-19 diagnosis would significantly alter your management. And I would argue that at least as of 15th April 2020 or 16th April in Pakistan, there's hardly a situation where a formal COVID-19 diagnosis would change your management, unless you were enrolling a patient perhaps in a formal randomized controlled trial, because all the sort of specific therapies that we talk about, none of them are proven, none of them are part of the standard of care. And then the other, caveat is you want to do it only when less invasive specimens such as nasopharyngeal swabs and tracheal aspirates from the endotracheal tube have been non-diagnostic. Another indication could be you're trying to do a BAL for some secondary infection. I've had one case where we found the patient to have pneumocystis pneumonia on top of COVID-19. But that's something we actually discovered using a simple tracheal aspirate, not a BAL. And then sometimes you have to do a bronchoscopy for therapeutic reasons at the bedside. If someone has respiratory compromise from hemoptysis, and you either need to suction out blood clots or there's massive hemoptysis and you need to place a bronchial blocker to prevent soiling of the contralateral good lung. Another instance is in case of intractable mucus plugging, where you've tried some less invasive measures, but they haven't really succeeded. What are the contraindications? If you don't have an experienced bronchoscopist who knows what ought to be done, or if the patient is very unstable. Now that's something where your clinical judgment comes into play, but you have to decide whether your patient is stable enough to withstand the transient compromise in ventilation when you will insert the bronchoscope through your ET tube or your trach tube. So preoperatively, there's a sort of a list of things that I sort of listed over here for you to consider before you enter the patient's room as the bronchoscopist. One, you should really have a clear mind about what are you planning to do and how are you going to go about doing it when you start doing your bronchoscopy. Make sure you have adequate personal protective equipment. And currently, as the standard of care, as of April 2020, that includes an N95 mask, face covering or equivalent such as a PAPR, a gown, and gloves. I would recommend also considering shoe covers and a cap if you're going to be doing something that is so high risk for aerosol generation. Make sure the patient's adequately sedated. I would recommend that you perform inline suctioning to make sure there's no cough or minimal cough. You make sure that the patient's not triggering spontaneous breaths on the ventilator. Those are things that would sort of argue against adequate sedation. And even if the patient's otherwise looking calm and even RAS of -4, i.e. not really moving unless you stimulate the patient, it's hard to know how they're going to react when you insert that bronchoscope. Make sure that you have the ventilator set on a mandatory breath mode, either volume control or pressure control. And make sure not only that you have a secure airway in place, such as an endotracheal tube or a tracheostomy tube, but that its cuff is adequately inflated, so there is no leakage of air around the endotracheal tube, again, to limit aerosol generation and dispersion in the room. Make sure to pre-oxygenate the patient with 100% FiO2 for at least 10 minutes. If the patient's still borderline hypoxic, after those 10 minutes, I would reconsider whether doing a bronchoscopy is truly worthwhile. Now, intraoperatively, during the procedure, it's highly recommended to have a negative pressure room if you have that facility available. The most experienced operator should be the one doing the bronchoscopy. You should really aim to be in and out and do your procedure as fast as possible. If you're just trying to do a lavage, it should take no more than a couple of minutes. Make sure you only have personnel that are essential to the procedure who are in the room. You limit exposure to staff. You should have a nurse. If you have a respiratory tech or someone else managing the ventilator, there should be that person. There should be an assistant to help you gather the specimens and such. But make sure that the people who are essential are really in the room at all times so that there is no delays during the procedure. You could consider a reverse Trendelenburg position in which the feet are slightly below the head of the patient. So this is not Trendelenburg, but rather reverse Trendelenburg, right? And this could help push the diaphragm and the abdominal contents sort of lower down. It can be particularly helpful in patients that are obese. It could help prevent de-recruitment of the lower parts of the lung when you insert your bronchoscope and presumably lose some of your PEEP, positive end expiratory pressure. If you have a disposable bronchoscope available, it would be best to use that and then discard it afterwards so that you don't have to clean it and there's no risk of cross-contamination of other patients. And then the CDC guideline recommends, collecting at least 2 to 3 cc's of fluid for adequate COVID-19 testing if you're going to be getting a BAL. Post-operatively, make sure you monitor the patient closely for pneumothorax, especially if the patient happened to have high airway pressures. Make sure you place the specimen in a proper bag and call the lab ahead of time to notify them that you're bringing specimens from a patient who's known or suspected to have COVID-19. If you use a disposable scope, great, dispose it off. And for any reusable equipment, just use your institutional policy for standard disinfection. And then very importantly, can't emphasize this enough, make sure you follow the appropriate doffing or removing protocol for your personal protective equipment. It's as important to take off your gown, your mask, your gloves, as it is to put them on, because you can inadvertently expose yourself if you don't follow the right protocol. So I listed over here sort of the CDC guidelines step by step for removing as well as putting on that PPE. You can simply Google, CDC PPE donning, doffing protocol, and these slides are available. There will be a recording of all of this on YouTube as well. So moving on now to the second of the 2 airway procedures that we're discussing today, a tracheostomy. As you know, we do this usually in patients who've been in the ICU for a while, and it looks like maybe they're getting better, but they're not quite ready to get off of the ventilator. So when should you do a tracheostomy? There's actually no consensus as of today for when to do a tracheostomy in any patient, much less a patient with COVID-19. There's wide divergence across institutions, even in the United States. I heard from some colleagues as recently as today that, for example, in New York State, some centers are really pushing for early tracheostomies in these patients, whereas in Washington State, one of the first states to be hit hard by COVID-19, their modus operandi was late trachs or preferably no trachs whatsoever. I think one of the considerations could be what kind of resources do you relatively have more? Do you have more ICU beds and ventilators available on a given day or during a given week? Or do you have a relative abundance of LTACs? LTACs stands for long-term acute care facilities for those who aren't familiar, but basically these are nursing home equivalents that are equipped with managing patients who are, who have a tracheostomy and who might require minimal ventilatory support. What do the current societies recommend? So there's the American Association for Bronchology and Interventional Pulmonology. And then there is the ENT Society, American Association for Otolaryngology and Head and Neck Surgery. And they both recommend against, an early trach policy. I would say, though, to be clear, the AABIP does not have a formal recommendation, but they have put out a podcast that talks about this a little bit. Both sort of favor letting the clinical picture become a little clear first. Make sure remember, a lot of the patients with COVID-19, the natural history of disease is such that they take a while. They take 2 to 3 weeks to really declare themselves. And most societies and most practitioners would recommend you don't jump the gun and, do a tracheostomy on a patient too early on during their course. Let's figure out what they're doing at least 2 weeks post-intubation. And then you offer a tracheostomy just the way you would for any other patient who's chronically on the ventilator, but is otherwise looking stable enough to potentially start thinking about getting out of the ICU and surviving this ICU stay. So what is that patient? That patient is someone who has low ventilator requirements, is normotensive, no longer has any other organ failure, but is perhaps just not able to get off the ventilator. You've been trying spontaneous breathing trials and the patient keeps failing, or you perhaps even tried to extubate them, but the patient got reintubated. What are the contraindications for tracheostomy? Similar to what we talked about for a bedside bronchoscopy. You've got to have experienced operator available, and you've got to have a patient who is stable enough for a tracheostomy. Of course, a bleeding risk is always a relative contraindication as well. So preoperative considerations include some of the same things that we talked about earlier for a bronchoscopy. You got to have the right PPE, and then also consider if you are thinking about doing a tracheostomy on a patient with COVID who's in your ICU, perhaps resend a tracheal aspirate and see if it comes back negative. Perhaps that means that the patient is now cleared and is no longer shedding active live virus particles. Though remember that COVID-19 antigen-based testing, PCR testing, has a limited sensitivity of approximately 70%. So you can never be sure, and you have to take adequate precautions. Ensure adequate sedation, as we talked about. Ensure adequate paralysis. The ENT Society thinks it is mandatory for patients to be paralyzed during a tracheostomy, and I would agree with that. And then some of the other things that we talked about earlier as well, I won't rehash that. So intraoperatively, again, you got to have a negative pressure room, the most experienced operator available, the right kind of staff support, but only those that are absolutely required in the room. Ensure that the positioning is optimal, just like with any other tracheostomy. They got to have their neck fully extended with a shoulder roll underneath the shoulders. Avoid electrocautery because that's going to lead to some aerosol generation. Use cold instrumentation if you have to, especially if we're going to be doing open surgical tracheostomies. Do not use a fenestrated trach tube. Definitely use a cuffed trach tube. The idea here is to make sure there's no aerosol dispersion in the room afterwards. And then the big question, should you do an open trach, i.e. a surgical trach, or should you perform a percutaneous tracheostomy, the kind that people like me, interventional pulmonologists, tend to do? So the ENT Society does not comment on perc trachs at all. For them, it's implicit. We're talking about open or surgical tracheostomies. The Interventional Pulmonology Society in America suggests you could use either method, whichever the institution is most comfortable with. If you ask me, I would argue that perhaps it's best for everybody involved to perform an open or a surgical tracheostomy in this case. And I'm assuming that this is the one that is most frequently performed in Pakistan as well. I think one of the advantages intraoperatively is that during an open tracheostomy, you have your endotracheal tube and the cuff that is below the incision site, not above. So you have a relatively closed circuit, even when you're operating. And then also for the percutaneous tracheostomy approach, you need a bronchoscopy, someone holding a bronchoscope during the procedure, which is in itself is an aerosolizing procedure, as we talked about earlier. And then post-operatively, some of the things that we talked about earlier, but then also make sure you keep the cuff inflated at all times, avoid any cuff leak, try to avoid any routine trach changes until the patient becomes COVID-19 negative if possible. And then once the patient's tracheostomy tube is off of the ventilator and the patient's really gone better, connect the trach tube with a heat moisture exchanger. I put in a picture of that so many people are familiar with what I'm talking about. That should have a viral filter or a regular ventilator filter installed as well to avoid any live virus shedding in the room. So to recap, I think both bedside bronchoscopy and tracheostomy in COVID-19 patients should really be reserved for when it's clearly warranted. Try to minimize these procedures if possible. Meticulous preparation before you enter the room is key so that there's no time lost trying to gather supplies or do other things or troubleshooting and then increasing exposure time inside the patient room. When you're in the room, maximize efficiency, minimize exposure using some of the thoughts that I shared with you. Strictly adhere to post-procedure guidelines and recommendations for safety and disinfection purposes. And then at all times, there should be no compromise on PPE, whether you're putting it on or you're taking it off. Here are some references, some additional reading. Again, these slides will be available on the YouTube recording as well. Thanks for listening. Happy to answer any questions.
Thank you, Majid, for a very nice presentation and touching base on some aspects, the tracheostomy, we're dealing with those aspects right now. So I think that's a useful topic. In fact, we had a couple of tracheostomy questions today. I'd agree with you about, I think OR is a little bit more controlled conditions and there's less risk of aerosolization. Otherwise, anyways, I'll just ask the panelists to introduce themselves first, and then we can take the questions. So let me unmute the panelists. Kaleem, please go ahead and introduce yourself quickly.
Assalamu alaikum, Kaleem Ahmed, Pulmonary Critical Care and Sleep Medicine.
Okay, I'm gonna go to Mariam, please introduce yourself.
Assalamu alaikum, I'm Mariam Morton. I'm a staff cardiologist in Loma Linda, VA.
Thank you. So I'm gonna ask Mudassir Raza, please introduce yourself. Mudassir, you can introduce yourself now, please.
I'm sorry. My name is Mudassir Raza. I'm a pulmonary critical care sleep doctor.
Thank you. I'm gonna Noor Mahal, please introduce yourself.
This is Noor Mahal Kabani, pulmonary critical care. I'm in Houston, Texas.
Thank you. Rosina, please introduce yourself.
Yeah, assalamu alaikum. I'm Rosina Badal Munir from Kaiser Permanente West Los Angeles Medical Center. I'm an ultrasound specialist.
Thank you. And I think lastly, Sajid. Dr. Sajid, please introduce yourself.
Assalamu alaikum, everyone. This is Dr. Sajid Mahmood. I'm critical care medicine and practice with OSF and Memorial Health Center, and also utilize my time with Advocate Aurora Electronic ICU.
Thank you so much. Okay, so I'm gonna go to the questions quickly, and I don't, for some reason, see any questions in the Q&A. Majid, do you see any
raised hand?
Okay, so I'm not seeing raised hands for some reason.
If you go to the attendees, there's Dr. Muhammad Salim seems like has a raised hand.
Okay, let me go to attendees. Okay, got it. So, Dr. Salim.
So I think you could move him as a panelist and then he could speak.
Okay, so sorry, I'm having a little trouble. Dr. Muhammad Salim, with 23.
Well, you can just allow him to talk. You don't have to move to panelist.
Yeah, no, I'm actually trying to find I cannot see Muhammad Salim. Yeah, now I see it. Okay, so Dr. Salim, please go ahead and ask your question. Sorry for it took a little while to get to you. You're unmuted, Dr. Salim. You can go ahead and...
Yeah, can you hear me?
Yes, we can hear you. Kindly, can you introduce yourself quick as well?
Oh yeah, thank you very much. Assalamu alaikum, everybody. I am Dr. Muhammad Salim Khan, Senior Consultant Physician. I am working in Kotli, Azad, Jammu and Kashmir. I have basically two questions. My first question is to Majid Shafiq. And the question is there any data on prone versus spine ventilation regarding mortality? And my second question is, that in children there is, I presume, less severe disease. Is that due to increased inflammatory response with increasing age, or due to decrease in ACE receptors with age, or some other reason? Thank you.
Thank you. Majid, go ahead, please.
Sure. Thank you very much for the question. So your first question was about prone ventilation and mortality. Yes, indeed, there's good data. There's a very sort of landmark trial called the PROSEVA trial, PROSEVA, PROSEVA trial from the New England Journal of Medicine several years ago now, and they looked at folks that had severe ARDS, acute respiratory distress syndrome, and considerable amount of proning actually did lead to an improvement in 1 month mortality. Related to that, there's been a lot of debate these days on whether we should do awake proning or proning patients that are, before they get ventilated. In other words, patients who are just on a nasal cannula, for instance, either asking them to just lie down on their stomachs by themselves or helping them, lie flat on their stomach as well. There's no good data behind that. It seems to make sense. There's plenty of anecdotal reports, and there's some ongoing trials. My center included is trying to start enrollments in a trial of awake proning as well. But at least for ventilated patients with ARDS, there is good data behind proning.
Thank you.
And the second question, Majid, you want to take?
I'm sorry, I didn't catch that question. What was that question? It was about ACE inhibitors, I think, right?
Yeah, I repeat that question. In children, I presume there is less severe disease. Is that due to increased inflammatory response with increasing age, or is it due to decreasing ACE receptors as they decrease with the age, or some other reason for less severity in children compared to the adults?
In
good
COVID-19. Sure, valid, good hypotheses. I personally don't have a lot of thought for that. I don't take care of kids, but yeah, all the data is suggesting that thankfully kids seem to have less severe disease in general. Any other panel members have any thoughts?
So anyone else wants to share in the panel? Yes, Mudassir, please go ahead. Do you have a comment?
Well, I just wanted to comment on the prone. In a lot of my COVID patients that I've taken care of now, the ones that are self-proning seem to have a lot of subjective improvement as well in their symptoms. And I think that's an important thing. Even in the non-ventilated patients, we ask them to prone themselves. And that's been subjectively helping, and objectively they've been staying off the ventilator and progressively getting worse. And these age groups that I've observed that in are usually in their 40s to late 60s, and are generally non-obese patients that are doing it. The ones that are morbidly obese are unfortunately unable to do that on their own. But just an observation.
Yes, thank you. So I don't think so. Any one of us has data at this point to suggest, what's the reason children have less severe. Part of the reason that has been shown is because they're exposed to coronavirus family viruses. They don't get it as much. But why do they have less severe? We don't know. Anybody else in the panelists that wanna answer that? Okay, so no pediatrician available here. All right, I'm gonna go to the next question then. Khalil, go ahead and ask your question, please.
Assalamu alaikum. My name is Dr. Khalil. My question is that, is the association going to announce courses other than ventilation that is not related to mainly COVID-19, COVID-20, that is courses on different medical topics? Thank you.
Sorry, missed your question. Can you repeat the question again?
Okay. Is the association going to announce courses on different medical topics other than COVID?
Oh, okay. So Currently, this is a COVID seminar, so we are basically doing different topics on COVID on COVID. However, APPNA Merit has all sorts of topics that are discussed on APPNA Merit forum itself. If you go on the APPNA Merit website, they have all different seminars, lectures, and others. So yes, I think Walid and Dr. Shahid can help there, Shahid Rafiq, if you have further questions. But this current forum is for COVID and associated topics. Does it answer your question?
Thank you. Thank you.
You're welcome. Okay, so I'm gonna go to the next question. I thought I saw another raised. Okay, so Mohammed, please go ahead and Mohammed Salim, please go ahead and ask your question. Mohammed Salim, you're unmuted. Okay. All right, let's see. Mohammed is not answering. Maybe some technical issues. Let's see question. So, there is a question by Dr. Sajawal. For how long we can keep a patient on tracheostomy? So I can answer, but before Majid or Mudassir or anybody else in the panel list wants to answer, you can raise hands. Majid, you want to take it?
Sure. You know, there's no real end date or expiry date. There are folks who get a total laryngectomy for laryngeal cancer, and they're left with no upper airway whatsoever for the rest of their lives. They stay on a tracheostomy for the rest of their lives. There are many other patients for all sorts of reasons. So the short answer is there's no end date on a tracheostomy.
Mudassir, you have anything to add?
Yeah, no, I totally agree. I mean, I was a director of a long-term vent unit here in Frederick, and we had patients that were on it for a year, 2 years, 3 years. I mean, there's, depending on the underlying condition, the trach stays in as needed, and we can change them out if they malfunction or anything like that. But there's no, like Dr. The other doctor just said, there's no expiration date on tracheostomy. Depends more on the underlying condition.
I totally agree with the two comments. Okay, so Khalid, that was your question. Is that right? So no, I think that was from the Q&A. Let's see. All right, so there is another question by Samreen Sarfaraz. I'll read out to you from Q&A. If we don't have negative pressure, resource constraints, only HEPA filters air exchanges, and COVID ventilated patients has been on the vent for 20 days, should one proceed for bedside tracheostomy or continue with ETT given the risk to others? Okay, so the question is kind of after 20 days, should we proceed for bedside tracheostomy or continue with ETT? I think in Majid's presentation, he touched base on the ENT guidelines from USA, but I'll let Majid answer that.
Yeah, you know, sure, it's really all risk versus benefit. Part of it, of course, like I mentioned earlier, has to do with the resources available. I will also say, you know, the CDC has published the engineering specifications for positive and negative, you know, pressured rooms. So rooms that aren't negative pressure today could become negative pressured next week. There are ways to do it. You should talk to your, you know, engineering folks. It's not necessarily a very big undertaking. Not to say it's not an undertaking of sorts, but something that you can certainly talk to folks about. If absolutely an aerosol generating procedure ought to be performed, of course you would have to, but then you do everything you can to minimize aerosol generation. And so one of the many things I might suggest is, like I said, you know, my bias would be perform an open tracheostomy, not one that is percutaneous. Also, you might have an operating room that might have negative pressure available. So perhaps you do transport your patient to the OR and perform the tracheostomy over there and then bring them back into the room.
Very good. And Samreen, I just want to add, as Majid also mentioned, with the ENT guidelines from USA, currently we are kind of waiting for, rather than typical 14 days, kind of 3 weeks at 21 day and reassessing. And at this point in our institution as well, both IP Society and ENT Society has no specific weightage, which way should we do a bedside tracheostomy. All of us do it here, but with COVID positive patients, we are letting the ENT do it in the OR under controlled conditions, as explained in his presentation as well, where you have much less risk of aerosolization. Okay. All right. So, Mudassir, do you have any comment, or anybody else has any comment?
No, I totally agree at this point in time. And also, when you look at the patient that's been on the ventilator for 20 days, you have to kind of look at where things are going. Are we going for hospice or palliative care? If they're not getting better or worse, or if they're getting better, you know, we have to really weigh the risk and benefits of a tracheostomy versus a delayed extubation. So I concur with what you guys are saying.
Very good, thank you. So I have another question from Imjad Hussain. Imjad, do you wanna, let's see if I can unmute you. Right, attendee. Imjad, you wanna talk live and ask your question?
Yeah, sure. Assalamu alaikum. Good to see you, Fawad. It's been a while.
Yeah, thank you. Oh,
yeah.
Imjad, hi, how are you?
Yeah,
Thank you.
I'm fine. Alhamdulillah, I'm fine. I have been following you, and it was so good
Thank
to
you.
see you.
Appreciate it.
Yeah, I just
Same here,
wanted
good
to
to
ask about, especially, I
Please
was reading
introduce
some.
yourself, Imjad. Imjad, bhai, if you can introduce yourself to all, so please.
I'm working in Pakistan. I'm Imjad Hussain. I'm working as a family physician here, and I had some research experience in US on
Absolutely.
Alzheimer's disease and other neurological disorder. But currently, I'm working as I would say, a medical educator, and
Okay.
just a family physician here in Pakistan, back
Very
home.
nice. Please go
I
ahead
just
with your
wanted to
question.
ask, I just wanted to ask about if we ask somebody to give a salivary specimen, for example, a patient is suspected with COVID-19, and we ask him to provide a specimen of his saliva on his own, instead of getting a nasopharyngeal or oropharyngeal one, like the swabbing we do, would it provide us a kind of equivalent yield in terms of testing, or it would be inferior? It's a bit of a tricky question. I do not really have an answer.
Yeah, I'm gonna suggest what I know, and I'll open it to other panelists as well. So there was a paper published from Wuhan, China, that did mention out of, I don't know, 180 patients, they did all three: nasopharyngeal, oropharyngeal, and BAL. The yield was 95% from the BAL. I think the oropharyngeal was somewhere around 40%, 38%, and nasopharyngeal was somewhere around 60 to 70%. Okay, so there is a big difference. So I would assume the salivary will be much less, close to 30, 40, but that may not be accurate. However, it will be lesser than the nasopharyngeal and lesser than the BL. But I'll open it to Majid and others, whoever wants to comment on that.
Yeah, I'd agree with that. And also the CDC guidelines currently recommend, going with the nasopharyngeal swab if possible.
Anyone else on the panelists wants to?
I mean, can you hear me?
Yes.
Yeah, I'm sorry. I think there was that article that you're referring to that was published in JAMA that showed that 63% of nasopharyngeal swabs were positive, and I think it was 48% oropharyngeal and 95% BAL. But as you know, BAL has its own risks. Dr. Shahid that told us all about that today. So I mean, at this point in time, the best test we have is available, 63% according to that study, 60 to 70% according to some studies. I mean, we've routinely having to test. I had like patients more than once if your clinical suspicion is high. A colleague of mine in New York actually told me he tested a person 3 times nasopharyngally and it was negative, and then finally he did a BAL and it was positive. I mean, he was just very convinced. Also, if you look at the nasopharyngeal swab, you're supposed to actually swab for 10 seconds which, you know, obviously most centers aren't doing. I mean, we had to educate our staff on that.
Okay, very good. Thank you. So I have another couple questions. I've unmuted. Actually, I did mute all the panelists, but I'll unmute again. Anyways, on the attendees, I have a couple questions. Dr. Muhammad Salim, please go ahead and ask your question.
Hello. My question is, in asymptomatic patients or in otherwise, what should be the schedule of repeat test to discharge the patient?
Very good question. All the panelists are unmuted, so anybody who can take that. Does anybody want to take it?
I think right now there weren't clear-cut recommendations. The CDC initially was recommending 2 negative tests for a person, a healthcare person, for example, that can return to work. However, I think they're relying more on symptoms. Generally, they're recommending a 14-day quarantine at home, or, you know, depending on when their fevers break, symptoms such as cough resolve. I think they're, at least in the United States, from what I understand and from my colleagues are doing, we're going more by symptomatology more than any testing, because as mentioned, 63%, I mean, nasopharyngeal swab is sensitivity. So you're missing almost 40% of cases, even when you're testing. But that's been my experience.
Yes. Anybody else from the panelists, Dr. Kaleem or Majid, anybody?
In Pakistan, what we are doing, this is Dr. Samreen Safraz. What we are doing is that we have a significant number of people who are asymptomatic. So those who do not have symptoms, we retest them at day 7. And if they are positive on day 7, we give them another 5 days to 7 days and then retest them. I mean, they go on along with that cycle. If after a single test they are negative, like on day 7, if they were initially positive and on day 7 they are negative, we basically de-isolate them. Usually what we are seeing in this trend, I mean, my colleagues in Lahore, they have quite a lot of people who are asymptomatic or have mild symptoms. Karachi has a more severe cohort, but Lahore has milder cohort. What they are observing is that the asymptomatic people are viral shedders for a long duration. So they're seeing that even if they go on retesting, they come out positive, and they have seen positivity even up to a month.
Yes.
So that's a problem. The asymptomatic cohort is a problem.
Yes. So very true. A couple of things I want to mention. 21 days. They can shed the virus for sure. It's in the studies, and then there has been some reports of feces up to 30 days or more. Now the question is, when we can, you know, on somebody who was positive, when can we consider them non-infective? So usually, CDC-wise, it's 2 negative 24-hour apart. Now there have been some new concerns of when after 23 or 26th day, in fact, one of our patients is still positive at 27th day after getting better. So the concern is whether there are some reports from South Korea that those may not be infective because those could be viral nucleotides which are still detectable, but they are not infectious. And there are some reports of doing a quantitative test. If they are below a certain limit, 10 is to the power of less than 5, then they're probably non-infective. But again, nobody knows exactly. If there is anybody infectious disease, they can comment. Or Majid, do you have any other thoughts on that?
No, I would completely agree. And I also listed a nice, there's a nice URL that goes over this and similar frequently asked questions that the CDC has nicely answered. And I think the long and short of it is, you know, you discharge the patients with COVID-19 just when they're clinically ready for discharge, just like any other patient, such as with the flu or any other respiratory illness. Obviously, you do want to continue to recommend that they exercise caution and take social distancing to heart. You know, here what we're doing is we're often just, you asking for one more, once they're asymptomatic, we will often have folks, including healthcare workers, just get one more test done. And as long as that's negative in 5 days or so, they're ready to come back. But coupled with that, we are now having everybody wear a face mask, a regular surgical face mask in the hospital at all times. So that helps.
Okay, very good.
Fawad, this is Sajid. Yeah, I agree with what Majid just said, that because we can make a indirect recommendation by what CDC has posted on their site to return regarding instructions after an illness and return to work. But they recommend that you can go back at like 3 days have passed since recovery, defined as resolution of fever without the use of fever reducing medications. And then at least 7 days have passed since symptoms first appeared. So I think according to that, that will give us a indirect recommendation.
But that's when you have symptoms. The problem is the asymptomatic cohort, and that's a very big problem, because they are viral shedders, and that's a prolonged period of time. When you have symptoms, it's easier to do because you can make a count of days from the time they have stopped having symptoms. I mean, say 3 days or 5 days, and a total of 7 days have passed, and then you can do 2 samples 24 hours apart. But in the asymptomatic people, they don't have symptoms at all, and they are shedding the virus for a very long period of time. So what we have seen and we've debated upon is that different guidelines are giving different directions for this cohort, and there's no, basically even I've also studied the CDC, and there has been, I mean we're not very satisfied with it, because whenever in whatever cutoff we see, they are still positive. That's a big thing. Very few people become negative in say 10 days or from the start of symptoms, or 12 days.
Yes, yeah, go ahead.
Go ahead, Sajid. Go ahead, please, Sajid.
Yes, so we have discussed in our previous sessions that that there is no recommendation to get another test to clear them or to label them negative. Yes, in the beginning, there is a window period where they can be false negative. So in that case, there is justification to repeat the test. But in order to get them clear, once they get asymptomatic, we have to use our clinical judgment, and also wait for at least 3 weeks. Once their illness is over, that is considered a safe period. But yes, exceptions can exist. And over there, we just use our clinical judgment.
Right. And I just want to add, I think both points are valid. And I've been in touch with some colleagues in England as well. And one of my colleague friends has COVID positive. And then he's, after 17th day, his COVID test came back positive again. And he's asymptomatic. And he's been allowed to work despite repeat positive after 3 days of being, if he stays asymptomatic. So I think it lands into the same category that after 21 days, if you're still shedding, whether symptomatic previously or asymptomatic, is it really infectious or not? And do not disagree with what Simreen and Sajid and Majid said. I think as time comes, we will know more about that. Okay. Any other comments on that before I move on to, let's see, there is another question. So who has a raised hand? Okay, Nusrat, please go ahead and ask your question.
Hi, this is Nusrat Ashai. I'm a nephrologist from Cleveland Clinic. Today there was some new information that is more concerning as we discuss the safety of returning these patients back to work if they're healthcare providers, is that the patients are actually now noted to be contagious and more infective even before the symptoms have appeared. I'm sure most of you have heard that news tonight, and that's disturbing news. My question then is, you know, the fact that they're shedding the virus, we have had enough cases. Is there no research being done? Because many times you have seen that these patients are discharged, they're readmitted within a week with worsening symptoms. So is there anybody, and I'm sure somebody is looking at it, that I'm not aware of that data, as to does the infectivity of the patient decrease with time? In which case, even though they are shedding the virus, just like Dr. Fawad said, if there is a titer that you measure and you say, okay, this is how we quantify and we can measure the infectivity of this patient, then only can we safely return them to their place of work or to their families without imposing quarantine again. So I don't have an answer, and working in a dialysis unit, that's a big problem for us as well, because these patients get discharged from the hospital, and because of the new guidelines now, exactly like they can return within 7 days after the onset of symptoms, and test-based strategies are less reliable in this setting. So
anybody wants to take it from the panelists?
So what about antibodies? Can't we do antibodies on them?
Fawad, this is Kaleem. I think we're still facing this dilemma. We do not have a clear-cut answer. So the antibodies, again, not everybody is going to have the same kind of antibody response that we know from the research. And then the presence of the antibodies does not mean if somebody is shedding still, or they are not going to be infective to others. So the data is still waiting. I think there were some people who are shedding more than 3 weeks. There were data was collected by the CDC to see whether those viruses are still infective or not. I have not seen any report coming out from there. One of my personal, a patient who is sarcoid, was on steroid, has a kind of moderate kind of symptoms, and then the discharge, and he has 3 tests the last about 2 days ago, and it's almost reaching the 4th week, and it's still positive, but he is totally asymptomatic. So we can only speculate about this. We don't have the answer.
Agreed. Jamleen, you have something? Okay. Majid, do you have, or Mudassir, do you have any comment?
No, I think what Dr. Kaleem just said, we're going to know more as time goes on. There is also, as you know, antibodies used as treatment. There are studies going on. I'm aware of one at Hopkins and one at Sinai in New York. So I think we'll know more as time passes.
Agreed. And I think antibodies basically is not going to tell us about shedding, as Dr. Kaleem mentioned. Let me get to another question. Let's see, Imjad. Imjad, do you have another question?
Yeah, I just wanted to ask about the viral sharing thing. I was just believing the nucleic acid amplification test, the RT-PCR test, it actually could measure the amount of virus. And just like in hepatitis C, we do the quantitative testing. So I was just wondering if it could be possible to know the amount of viral shed from a specimen.
Right. I think that's what I mentioned from the South Korean report. Also, it was there. I'm not aware of anybody, that is using that. Anybody else wants to comment from the panelists on Dr. Imjad's question?
I have not seen anything so far in the literature.
Yeah, so probably we'll know as the time comes along with that. Okay,
I would like to add. I would like to ask a question if it's possible. If you have any experience of serological tests for diagnosis, because we all know that the sensitivity of the PCR is 70%. Kits are in short supply. So, what's the experience of America about using rapid antigen-based tests or antibody tests? Anything in the market or anything being used in any hospital?
I will let Mudassir, you want to comment?
I must say, I haven't seen much out there yet. There are. I think the FDA approved 3 tests, but but I don't think they're very good, to be honest with you. They're having their own troubles and everything. So Dr. Fossey, as you know, he said it was a few weeks coming, but I think it may be even longer than that. I mean, I know people who took a test already. I know one person, my younger brother, actually, he was positive, and he took it, and he told me he has antibodies. But again, you got to take that with a grain of salt, because if you were infected with other viruses in the past, it's going to come up as positive. So I'm not sure we're going to get a whole lot of good from those tests, at least in the form they are right now. So I'd love to hear other people's comments on that.
Go ahead. Oh, Karim, go ahead, please.
So I think what Mudassir is saying is still, this knowledge is still kind of, we are all waiting for that. The antibody response, IgM and IgG, has its own timeline. So we have to figure out what exactly we are looking for. So if in the current scenario, if we are looking to find the patient who are suffering from this disease, either they are silent carrier or symptomatic, I think the best thing which has RT-PCR, because the antibody test is not going to be used for screening a large percent of the population and doing something to quarantine the separate from spreading the disease. The immunoglobulin test will be useful in terms of clearing if we have reached to that point by knowing that what kind of titer is going to be required. Is it 1 to 80, which was used in the convalescent plasma therapy, and if I remember correctly, in the MERS, or 1 to 160, which sometime proposed to be a better marker as far as providing the real immunity. We don't have those kind of data yet.
Great, completely. Okay,
so it would be interesting. Yeah, it would be interesting to know. Okay, for instance, if the PCR is still positive, in that scenario, I was thinking of a use of a neutralizing antibody, because if a person is shedding the virus, is asymptomatic, day 21, day 22, and we have something to show of a neutralizing antibody present in his serum, then we can easily say that he's not that much of a risk and he's okay. And this viral PCR is not basically showing infectivity. I don't know if that, yeah, but I don't know if any studies are ongoing or what is happening in this regard.
So I would be very cautious about this. The thing is, the person who is shedding, whether that person is not symptomatic and has antibody response, he's protected himself, but the virus which is shedding is just a nucleotide which is positive by the testing, or it is still infective to the others. So these are two different type of
questions. So that's the big $1 million question in this situation.
And we don't know the answer.
Not
you know
yet.
what I mean? Why am I'm asking this? Because the cohort in Lahore, many people, they have been forcibly put into institutions, and it's been, the third week or fourth week, and they're asymptomatic completely. They were asymptomatic from the start, but they were just positive. And they are now having a lot of mental symptoms because of this isolation, persistent isolation, and they require counseling. Some are getting suicidal. The reason is because of this is prolonged solitary confinement, which doesn't seem to end. And the answer is also with no one, because the policy over there of the Punjab government is that they would not let anyone go home until the PCR is negative.
Good point. Yeah, no, I think as time comes, we'll know more. I was about to ask last question from Sajawal. Dr. Sajawal, please go ahead and ask the question. Dr. Sajal, you can ask your question. Okay, so I'll ask another attendee has a question. I've unmuted XT1254. You have a question? XT1254. I don't know. There is no name. Okay, so I'm not sure if the attendees have left who had asked the question. Dr. Sajal's question was, one of healthcare workers has self-quarantined after exposure to a COVID positive relative and is supposed to have her COVID test at day 14. She's asymptomatic. What are further guidelines for her? Okay, so question again is, one of healthcare workers has self-quarantined after exposure to a COVID positive relative and is supposed to have her COVID test at day 14. She's asymptomatic. What are the further guidelines for her? Anybody wants to take it in the panel list? So I would say, I mean, 14 days is good enough for quarantine at this point, although we know 21 days is the shedding time, but after exposure, current guidelines for 14 days, if test is negative, I think she should be good to go. Any other comments, questions, concerns from anybody in the panelists before we finish the meeting today?
Agree. I think that's the right we should take.
Very good. Okay, thank you so much, all, and appreciate all the panelists, appreciate all the attendees for the nice session. As mentioned, it's on a nightly basis. Please feel free to join and ask any questions. For now, we will conclude the session. Have a good night. Actually, good night in USA and good day in Pakistan. Khuda Hafiz.
Khuda Hafiz.